So we've done a number of didactic blitzes over the years on suicide, and for good reason. By now, I feel like we have a shared understanding, or at least hope we have a shared understanding that suicide is not really about death per se, but about a desire to end an intense feeling of suffering. Yet one topic within suicide that I don't feel like is discussed enough is the relationship between suicide and chronic, severe, intractable pain. But I want to start from maybe a more broad perspective on suicide first. If I can get my slides to move. So looking at the scope of suicide, in 2018, the Centers for Disease Control had announced that the suicide rate in the US had risen 30% between the year 2000 and 2016, reaching a rate of 13.5 per 100,000. Notably, if these suicide rates continued at the current trends, an estimated 54,000 individuals per year would die by suicide in the United States by 2025. And for every death by suicide, even more individuals make a plan or attempt suicide. And in 2021, it was the fourth leading cause of death for individuals aged 15 to 29 globally. There's a good number of well-documented risk factors for suicide or for death by suicide. So being an older male, being an individual of the LGBTQ community, indigenous persons from the from the Americas, white Americans. There's a number of global and socio-political factors that have been shown to elevate risk, and of course, mental illness. And as such, a lot of the prevention trends have focused around mental illness, restricting access, training in healthcare providers, addressing media coverage, and all of these are really important. But as noted by NESDAT and others in 2020, they're not going to stop the majority of suicides. So when universal screening has been employed, over 60% of people who ultimately die by suicide had been, when asked in their previous clinical encounter, had denied suicide ideation. So it begs the question about what we can do to reduce the causes of suicides, really, and that we're looking at reducing the causes of suffering. If we're not really attempting to target the source of the suffering, then it seems like we're always responding to it in a reactionary fashion rather than a proactive fashion. So two major additional factors that have been linked to elevated risk for suicide that I've again said I don't think get nearly enough discussion, particularly in the world of mental health, maybe more so in primary care, but not from what I could see, is chronic disease and disability and then chronic pain. Both of these have fairly well documented risk within the literature for an elevated risk of suicide, and it makes sense. I mean, we think about suicide as a means to end suffering. These conditions cause a great deal of suffering. Patients often feel a reduced quality of life, a sense of helplessness, hopelessness, in addition to that just concrete physical suffering that comes along with the chronic disease or the chronic pain. So chronic pain and risk for suicide. The rate for individuals with chronic pain is 2 to 3 times higher than that of control subjects, and the number of attempts is even higher than that. So in some studies, they looked at death by suicide among veterans with severe pain compared to those without severe pain, and there was a 39% increased risk. And when controlling for mental health conditions, other medical conditions, and demographic variables, they still found pain severity to be strongly associated with suicide mortality. In a study that looked at 18 states between the years of 2003 and 2014, it found that 8.8% of individuals who died by suicide had evidence of chronic pain prior to their death. And you could see that those numbers increased from 2003 at 7.4% to 10.2% in 2014. Out of those individuals who died by suicide with chronic pain, 24% of them had spine pain, and over half of them had at least one comorbid medical condition. So it's then important to take a look at the scope of pain. If we're having this many people with chronic pain who die by suicide, the scope of pain is pretty intense. About 25 million adults report having some type of level of daily pain. And 10.5 million of those individuals report considerable daily pain. Chronic pain is correlated with higher rates of anxiety and depression and substance use and use disorders. So digging into kind of some speculation on why there's this elevated risk for chronic pain and suicide. So depression, obviously something that would make a lot of sense. If you've got chronic pain and comorbid depression, it looks like there's a bidirectional relationship with chronic pain where both are a risk factor of developing the other. Some catastrophized thinking regarding the believed controllability or uncontrollability or inevitability of pain, habituation, possibly reducing the fear or inhibitions to a temporary increase in pain in order to stop the suffering entirely. A thwarted sense of belongingness, so a subjective feeling of detachment and isolation away from meaningful social connections. And I mean, when you think about that, I mean, that's not only just family and friends, but people may lose the ability to work or engage in social activities the way that they once did when they have chronic pain. People with chronic pain also have been shown to have a high prevalence of sleep disturbance, and persistent insomnia and poor sleep quality have independently been linked to an increased risk of suicidality. So this sleep disturbance might be interrelated with chronic pain, where there might be pain intrusive thoughts that impact your ability to sleep, at sleep quality. And looking at data from 2003 to 2013, individuals who died by suicide compared to matched controls, sleep disturbance and non-cancer pain within a year prior to death, where the sleep issue started after the pain, those individuals were nearly twice as likely, those who died by suicide were twice as likely to have chronic pain and 4 times as likely to have a sleep disturbance. So lots of these interrelated factors between the sleep disturbance and the chronic pain. And I'd mentioned some of these stats on the previous slide. But so looking at individuals who have chronic pain, another place that you really want to look for is a sleep disturbance also, because now we've got this additional impacting factor that could increase the risk substantially. The overall picture that I think is important to talk about with any of this is that we need to be aware that chronic pain, particularly severe intractable pain and chronic disease, are important for us to look at when we're looking at suicide. And it's important for us to figure out how to better manage pain in order to reduce suicidality or deaths by suicide. Pain management is very complicated. It's difficult. There's not a one-size-fits-all for pain. Or pain management. One of the things that you hear from physicians and even post-surgery kinds of things is everybody's different. So that means that some people do really well and some people do really bad, and there's not a whole lot of rhyme or reason sometimes to why that is. Many patients with chronic pain are not sufficiently treated for a whole host of reasons. In COVID-19, one of the things that we saw is that there was certainly a lack of considering chronic pain management to be urgent. So when things were shut down, the ability to maintain pain management could be disrupted. There's obviously all of the policy shifts since the opioid issues and opioid epidemic. And while those policy changes that limit and restrict opioids might be of great benefit to the general public, they could create some new and complicated barriers to pain control for certain populations. Not only people with chronic pain, but individuals with cancer as well. Many patients are on the wrong medication, or ineffective medication, or an under-effective medication. There seems to be an overlap in the neural system and the physical and psychosocial aspects of pain, and they're all potentially linked to suicidal behaviors. And the percentage of individuals who suffer, what I think is interesting in the piece of all of this, when you look at things like pain management, and so much of the opioid epidemic conversation has been surrounding restricting use of opioids or looking for other things to manage pain, is that then we start to convolute this idea between people developing a use disorder and prescribing opiates. And not that that doesn't ever happen, but looking at some of the studies around it, it looks like people with a substance use disorder, actually 94% of those individuals, the substance use disorder was evident before the pain symptoms ever started. So if we were to better screen for substance use disorder before starting pain management, we might have a better sense of how to really address the pain in those individuals, or at least have a better sense of who we need to be watching a little bit more closely. In terms of protective factors, well-rounded healthcare is absolutely something that we know works. So I'd like to refer you guys back to the presentation that Tessa Basco did last March on the 25th. We do have the YouTube video of that, where think the title of the presentation was Living with Pain, but it was looking at the program that they have in place to really look at kind of some psychotherapy options for individuals, and giving them some sense of control and breathing techniques, and addressing some of the catastrophized thinking and the pieces of that you can through emotional and psychological methods. Cognitive behavioral therapy can be very helpful, but we have to manage the pain first. And frankly, for some individuals, just a belief that a solution exists might be a protective factor against suicidality. So here's my long list of references. Could have probably added additional, but this is the ones that I leaned on most heavily. And I will stop my share if I could figure out where my toolbar went.